Well, good evening, everyone, and thanks for joining me. My name is Dr. Ben Moralia. I'm here to talk about clear aligner therapy, how advances in monitoring, service, and specialist support allow adding orthodontic treatment to your practice today. So we have Candid Pro as a sponsor of this meeting, and I am also Candid Pro faculty. So as far as the disclosures go, of course, as Candid Pro faculty, you should know that in advance of the meeting. So here we go. A little bit about me. I graduated from dental school in 1993. So I have now been practicing for 29 years. I've been doing a lot of, for the past like 19 years, I've been doing a lot of early growth and development, interceptive orthodontics, phase 1 type treatment. And I do lecture nationally and internationally on clear aligner therapy, as well as craniofacial growth and development related to sleep disorder breathing. I'm a big fan of expansive orthodontics in all categories. And tonight I'm going to share with you a little bit about my experience in the clear aligner space. So the agenda, basic principles of tooth movement. Most of us know those. We'll just touch on those a little bit so you could recognize, it applies to all clear aligner systems. But a brief history of clear aligners, some critical differences in our manufacturing, the materials, the mechanics, and the monitoring, and the messaging and the workflow and how that goes. A little bit of treatment planning, the technician versus a specialist support. We'll have some case reviews just to share with you to give you an idea of what the remote monitor patients can look like. And at the very end, we'll cover some Q&A. We have an hour-long presentation, including the Q&A. So, this will flow pretty rapidly. Those of you who are already working with clear aligners, have a good working knowledge of them. So this won't be completely new to you. As far as the bone biology goes, your masticatory forces do help turn over and maintain healthy bone throughout the process. Called bone remodeling. So just using your jaws keeps them very healthy. And like any other thing in the body, there's turnover over time. And the using the oral musculature helps keep a healthy oral environment. When we talk about moving teeth, we do talk about pressure tension theory. And of course, with pressure tension theory comes osteoblast and osteoclast activation. So you're going to have, on the pressure side, you might have osteoclast activity where you're removing some bone. On the tension side, you get osteoblast proliferation. So you're going to get deposition of bone. Basically, what you're doing with orthodontic tooth movement is producing controlled inflammation. With controlled inflammation comes the osteoblast and osteoclast activity. The difference between fixed braces and clear aligners is very different in this category, because when you have fixed braces on, there is always a pressure on one side and always a tension on the other. So fixed braces lend themselves more to saying accurately that with fixed braces, you're moving teeth through the bone because you are putting pressure on one side and tension on the other the whole entire time. Whereas clear aligners, it's a little bit different because you're not wearing them 24 hours, 7 days a week, 365. There's a difference. So when you place your clear aligner, it's moving the teeth in a certain direction. But when you take your clear aligner out, which is the routine daily for breakfast, lunch, dinner, coffee, wine, etc., when you remove your clear aligner, there's instant relapse. So when your clear aliner's in, it sets up a pressure side and a tension side. You're moving the teeth in a certain direction. When your clear aligner is out, that's reversed, because relapse, now the teeth go the other way. So the pressure and tension is flipped. So what you're doing with removable clear aligner therapy is you're cycling pressure and tension. And the moment you cycle pressure and tension, you increase the amount of osteoblast activity and you decrease the osteoclast activity. Basically, what you do is you end up tipping the scale in the bone deposition category versus the bone resorption category, which is why you have more favorable tooth movement with a removable technique. So thanks to having a removable appliance, clear aligner, you have a more favorable bone remodeling going on because you have an opportunity to cycle pressure and tension. So the pressure tension theory can be absolute if you're talking about braces. You get some damage to the gum, the bone, the roots, if you apply too much force or you keep it going for too long. Whereas with a removable or a clear aligner, you're cycling the pressure and tension. So you don't have an absolute pressure tension theory. You have a cycle of pressure and tension, which allows for a predominance of bone growth. So that all works in our favor whenever we're using clear aligners or removable orthodontic techniques. So is there a need? Well, if you're in the clear aligner space or doing any type of GP orthodontics, well, you know that probably 3/4 of your teeth, 3/4 of your patients have teeth in a malocclusion. And so any patient that doesn't walk in looking like a typodont model with perfect occlusion has a malocclusion, and whether it's of the mild, moderate, or severe variety, you have an opportunity to improve their oral health by correcting their malocclusion. So we have the research that shows at least 3/4 of our patients have that. When you're thinking about, is it purely cosmetic? Well, straightening teeth makes you look better. You have a nice smile, certainly, but straightening the front teeth might only be cosmetic, whereas if you're moving all of the teeth, you have a chance to improve the malocclusion. So I'm a big fan of moving all of the teeth. And, with the candid approach, we are committed to moving all of the teeth. We don't do anterior alignment alone. So as you're moving all of the teeth, you can produce a nicer smile because getting all the teeth where they belong is your best look. Then, of course, when you upright the posterior teeth and deliver a more vertically loaded occlusion, you're going to be removing that horizontal strain or occlusal trauma that those teeth are under. So any teeth that are leaning lingual receive horizontal loading and are under occlusal trauma. So all of a sudden, when you upright all of your teeth and you have them connecting perfectly, you have a protective bite. So we can conquer all of these things by moving the teeth into a nice occlusion. Correcting a malocclusion delivers oral health, and it can decrease occlusal trauma. It can reduce abfraction and gingival recession. You can have improved oral hygiene with teeth that are closer to where they belong. Obviously, they're easier to clean. And having a beautiful smile leads to self-confidence. So all of these things are kind of known to the dental industry as far as being able to deliver them with clear aligners. When you're thinking about function, of course, you can think about straightening the teeth and aligning the teeth in a beautiful occlusion, which can improve your chewing function. It can lower your risk of gum disease. It can reduce your TMJ symptoms or problems, and done properly can improve your airway health. That's not the least of which should be an importance to us in delivering more room for the tongue. So anytime we're thinking about crowded teeth, well, the crowded teeth are closer to the tongue, and less tongue space is bad for breathing. A tongue that has less room is posteriorly displaced. So one of the components of better breathing is that you have more room, or the most amount of room, for your tongue to live in. And when you're uprighting all the back teeth and aligning all the front teeth with a little procline, so expand and procline are our two fancy words, you're automatically delivering more tongue space, and good things happen when you deliver more tongue space. So when you're thinking about this slide right here, you've got a little bit of research that we've come up with. Over time, we learned from patients what influenced your decision most when selecting orthodontic treatment. It turned out cost and convenience were the top two. So patients in this survey reported that the cost at 73%, 73% of this group responded cost was number one, and 70% recorded convenience as number two. So that's very nice to know that with cost and convenience being the top two, if you could conquer those two categories, you have people deciding to do orthodontic treatment. And so we believe we've got a nice system that addresses both the cost and convenience for clear aligner therapy. All right, so if we think about the evolution of clear aligners, it does date way back. And in 1945, H.D. Kessling pioneered the concept of straightening teeth without braces. He invented the positioner. So those of us who have seen or heard of tooth positioners, they originated in 1945 with H.D. Kessling, and the tooth positioner was a thicker version of what we call aligners today. By 1959, Henry Isaac Nahum introduced vacuum forming, and this was the dental contour appliance, they would call it. So here comes your thermoplastic material getting, vacuum formed, heated, and then vacuum formed over a molded set of teeth. And of course, this is where we were able to start making so-called clear appliances. By 1971, Robert John Ponitz proposed a vacuum-formed clear plastic appliance for finishing and orthodontic retention. And all of a sudden, we got into appliances that looked like aligners at the time, only it would cover the whole palate here, and it would go onto the gingival areas, and you'd have, basically the history of the clear aligner evolving into what we currently use today. By 1985, Dr. James McNamara, who's at the University of Michigan, the BioStar positive pressure forming machine, 1 millimeter thick biochrome polymers were used here. And so here you have a next step in the evolution of getting to clear aligners. And then that brings us to 1993, where John J. Sheridan introduces the Essex retainer. And it was then at the time 0.030 thickness, and with a dimple plier could be used for minor tooth movement. So again, it would be thermoplastic, it would be formed with heat and vacuum. And next thing you know, with a dimple plier, you started to do minor tooth movements with this. And then that brings us to 1990, 7, where Zia Chisti and Kelsey Worth are 2 Stanford MBA students. They partner with 2 orthodontists to found Align Technology, which introduces the Invisalign system to orthodontists in 1999. So here you have the beginnings of the clear aligner industry with Align Technology in 1999. That brings us to today. And today, what we're looking at here is what Candid has. It is a fully remote monitored orthodontic ecosystem with an app on your phone. You can take photographs to allow us to monitor the treatment process. Obviously, the clear aligners are on the left and a little case to travel around with them. So the basics of the system are that you have a clear aligner system that uses app monitoring, and with the app and scans of the aligners being worn, basically you have a system that can be done fully remote, and the doctor then can decide when and if the patient needs to come in on intervals that are okay with them. The opportunity then becomes you're welcome to see the patient as often as you need, but you can also provide convenience to patients who are either traveling distances to see you or would like appointments spaced further apart. You don't have to lose control or visualizations over it because the 2-week monitoring allows you to see their scans on their 2-week interval, and you know that they're progressing beautifully with this type of monitoring system. So not all modern aligner systems are the same. A few things are different, and we have a few differences that we'll look at just to see, where we are with our process. As far as the accuracy goes, the model accuracy is very important, and that does continue to improve over time. We are using the carbon L1 printers, and with the carbon printers, those have proven to be the most accurate right now. And so when you're thinking about accuracy of models to casts, well, less than 300 is the orthodontic minimum. And in leading brands, they've shown at 170. The carbon printers are under 100. And so when you're thinking about less than 100 micron difference from model to cast as far as the accuracy goes, you basically have the best accuracy. If you have the best accuracy in producing that model to your cast that you're going to make your aligner on, now you have your most accurately formed aligner. And then, of course, an accurately formed aligner gives you better control throughout treatment. So the carbon L1 printers are the most accurate today. So obviously we are using those. When you're thinking about the wear intervals, they do matter. And so traditional inpatient, the in-office patients are told to advance your aligners on a fixed but arbitrary level of the 2-week mark. And so whether you are changing your aligners at exactly 2 weeks or sometimes using 1 week, the issue is that over the course of a case where you may have 25 aligners, there's a fair chance that somewhere in there, a tooth or 2 or a set of movements required more than 2 weeks time. And if we arbitrarily assign a 2-week program and go all the way through, the chances of having a perfect finish after 1 round of aligners is very small. Well, the idea becomes if you have an opportunity to scan a patient every 2 weeks to record or basically analyze the fit of the aligner, if the software is sophisticated enough and it can tell you that every tooth is tracking beautifully at this point, you would know to move on to your next aligner. If a tooth or 2 or more didn't keep up with the movement that should have been expressed during those 2 weeks, then the software will notify the patient, wear that aligner 1 more week. The difference is that if during the course of 25 aligners, there was an aligner or 2 that could have been worn for an extra week to ensure the tracking to finish on time, this software would provide for it. Whereas if you didn't have that, you'd wear all your aligners, you'd get to the end and maybe you're 90% done, maybe you're 95% done, maybe there's a little more to do, you get refinement aligners. Whereas if you could pause and follow the tracking and wear an aligner a little bit extra along the way, you could take away all of the additional aligners or refinement process by having the remote monitor and scanning be accurate enough to have your patient wear them just a little longer when needed. So basically what happens is your compliance does matter. We still need the patient to wear the aligners beautifully, but basically the remote monitored aligner should put a premium on comfort to ensure maximum compliance at each aligner change. In other words, if you've worn your aligner perfectly and it has accomplished all of the movement that should have been expressed, moving one aligner to the next shouldn't slowly increase the pressure or tension on the teeth. The patient really shouldn't notice a difference from one to the next, because if you're wearing the aligner appropriately, every aligner should feel similar going one to the next with a very slight amount of pressure on the teeth. It should be as comfortable a process as possible. And then, of course, if you are using these EnduraFlex material, it does have the lowest but most constant force. So you end up in the most comfortable category, and comfort leads to compliance. When you're thinking about durability, the ZenduraFlex outperforms any of the other materials. So with the ZenduraFlex material, you're in great shape. You can maintain your clinical force level for even an extended wear interval. So should the patient need to wear an aligner for a third week during treatment, you would have the capability to do that with the ZenduraFlex material. The ZenduraFlex that we're using is completely clear. It doesn't have any striations in forming it. So it's a clear surface and it is stain resistant. So whether you wear it for a day or 3 weeks, it will look the same at that mark. So when we're thinking about the trim lines do vary across different companies. And so, of course, there is research from UNLV that was published in 2012 that a straight trim line 2 millimeters above the gingival zenith delivers significantly greater retentive forces than a scalloped gingival design. A straight trim line decreases flexibility, improving the probability of expressing a greater amount of tooth movement and more complex movements. So when we look at these trim lines, the top picture is scalloped. So it is scalloped. We follow the teeth only. We don't really get into the tissue line. Then the middle picture is the red line where the gingival cut is just straight. So you've got your trim line cut straight. The bottom line is the one that is cut covering about 2 millimeters of the tissue. It's that cut that shows better tracking over time. It gives the aligner more rigidity. And when the aligner has a little more rigidity, it will help you express the movements that we'd like to. The picture on the right side and the bottom, of course, shows how the model is formed into the gingival undercuts and how that cut is 2 millimeters onto the tissue. That extra little band of the aligner material gives you the rigidity and will basically decrease the flexibility over time, improving how that's going to express all the movements in the teeth. We're basically taking that aligner and giving it more ability to control the tooth movements and deliver excellent movement. We're trying to reduce the number of times you have to request additional aligners to treat your patients. So it turns out the 2 millimeter above the gingival zenith is the best place for having the better retentive force for an aligner. So as far as attachments go, the attachments can be overrated, and whether you need all of them remains to be seen. So I have 19 years experience using clear aligners, and so there was a time where I was using attachments, of course. Using the Candid appliances, I use them without attachments, as Candid is a non-attachment type of technique. So the idea is when you have a clear aligner that does not block out the gingival embrasures and undercuts, and then is cut at the 2 millimeter mark onto the tissue, you have the aligner sinking into all of the gingival undercuts around each tooth. So at the mesial and distal, that aligner engages the tooth everywhere. When you engage a tooth in the undercuts, basically what you've done is you've transferred the tooth to be the attachment. So now with that type of cut and form into the gingival embrasures, your tooth is now the attachment. So as long as you sink into all of the gingival embrasures and engage in all the undercuts, you have the opportunity to make the tooth the attachment, which means all of a sudden you don't need to put an individual attachment on the teeth, and you can do a whole lot of clear aligner therapy without any attachments. My pathway to no attachments didn't begin with Candid aligners. My pathway to no attachments began about 5, maybe 7 years ago when I started reducing the number of attachments on cases. And by taking away the attachments and reducing the attachments that were in the cases, you start to recognize how capable aligners can be. And then you figure out that, maybe we could do this with 2 attachments or 4 attachments instead of 10 or 12. And so over the last 5 to 7 years, I was working my way out of the attachments. And then, of course, sure enough, Candid comes along and has a no attachment technique, which interests me tremendously. And now I use clear aligners without attachments as the routine. So when you're thinking about blocking out the undercuts, now, if you do block out the undercuts, then your clear aligner has less clinical grab. It will stop at a height of contour. It will not engage into the undercut, and it will have less ability to track and move the teeth. And then, of course, when you get into more challenging movements, you have a little bit of a loss of the grip as the aligner and tooth are not fully engaged because we're not getting involved in any of the undercuts. But all of a sudden, when we start to engage the undercuts, when the aligner is formed past the undercut or height of contour of the tooth and engages into the areas where we would call gingival embrasure sites, all of a sudden now we have significantly more tooth contact with a full contour around into the undercuts, and you're getting attachment-like force vector out of this. So you basically turn the tooth into an attachment. So you couple this with the properties of the aligner material, and you're getting a beautiful force over time. And of course, you're allowing it to fully express because we're going to use the dental monitoring or scanning to prove that, hey, in 2 weeks' time, we did accomplish everything we were supposed to do. And if we didn't, then the scanning will respond to the patient and let them know you should wear your aligner for another week. This is what that looks like. So when we're thinking about the monitoring, this can eliminate a lot of routine office visits. Now, it doesn't mean you have to. It gives you the opportunity to reduce the number of office visits. So basically, when the patient receives their aligners and they put the first one on, they take a scan. You have a little scan box, your phone attaches to it, the app opens, and in a mirror, you'll be watching the instructions. You touch the screen, and it takes an image and a little bit of a scan of your aligners and the fit. The software, of course, is sophisticated enough to know that the aligner is fitting beautifully well. So on day one, you take a scan of the aligner one. When you get through the 2 weeks, you take another scan. If that aligner was worn appropriately and everything tracked beautifully, it will register and the patient gets a notification. Congratulations, put your next aligner on. Now, along through treatment, if the patient, let's say, has a bad week and doesn't wear it as well as they should have, you might take that scan at the 2-week mark and it might say, you should wear this one more week. Now, that's not the full tracking. So wear it an extra week, scan again. You wear your aligner anywhere from 4 to 7 more days, scan again, and if the movements were expressed, it will tell you then to move on to your next aligner. Part of this will encourage compliance because the patient knows every 2 weeks they're going to take an image that then a software program is going to respond to them. You did a nice job, move on, or you didn't, you got to wear it an extra week. So now this type of monitoring does allow you to eliminate routine office visits. So when I first began, I was having the patient come in at a certain interval. They were doing the 2-week scans. And of course, you have access to see those online. So you can go right into your doctor's site and pull up the scans and kind of watch those. And we'll see when we look at a couple of cases how that looks to you. But you can take a look every 2 weeks if you wanted to see, the case progress. And if you decide that you have a patient who's either lives too far away or has a work schedule that's very difficult to get to the practice, this is a very nice opportunity because now, should you choose to, you can go all the way to the end of the spectrum and say, if you come in for your first visit just to get the records and get started, you can take your scanning and track all the way through the case. You could come back on the last aligner. And all of a sudden, you can shrink this to 2 or 3 visits if that would help with the convenience aspect of it. And remember, the convenience was reported to be number 2 for patients. So they're looking for some convenience. That doesn't mean you have to take every single case from start to finish and not see your patient in the middle. Dentistry is a bit of a relationship business. So, if you want to insert a visit or 2 in the middle, you can reduce the routine office visits to a point that is a little more manageable, and maybe it frees up a little chair time and takes a little strain off the practice. Whereas you would normally be seeing the patient on every 3 or 4 or 5th aligner, you could stretch that just a little bit, but have total control through the monitoring. You know exactly where your patient is every 2 weeks. So it looks like something like this. When we see our patient tracking, every 2 weeks, they take a scan. So on top, the bar outlines number 1 all the way through number 16. And as the patient's walking along, you could see at number 7 was worn for 2 weeks. And the patient was told, no go, don't go ahead, wear it 1 more week. They scanned 1 more week later and got the ability to move on to number 8. And then when they got to number 9, you could see the little red box. Number 9 was scanned after 2 weeks, but they were told, no, wear it 1 more week. Scan at number 9. Now it was appropriately tracking. Same thing with 10. So basically what happened here was this patient wore 16 aligners to complete their treatment, but number 7, number 9, and number 10 were worn for an extra week. So 3 weeks of wear were added to the case by the scanning app. And of course, with that type of monitoring, those 3 weeks kept the patient on track to finish at 16. So by the time they got to 16, they were finished and didn't require any other aligners. It basically, those 3 weeks can keep you on track because once you're a little bit off track, it tends to ride all the way through. So if you've used clear aligners before and you get a tooth or 2 that are a little off track, all of a sudden what happens is it can kind of snowball. It can maintain the level of distance it's out of position, or it could get a little worse over time. Whereas if you allow the liner to have just a little more time, you can keep yourself on track and finish the case on time. So that little bit of monitoring goes a long way to eliminate possible refinements. So not all monitoring is the same. There are, design it yourself, and then there's the candid monitoring. So you have these 2 different worlds here. Designing it yourself is a little more complex. There's lengthy training and a learning curve involved, and it requires a dedicated, staff to make sure you're following all of this. That could be an additional cost per month or per case. There's unlimited customizability there. your target user would be a high volume ortho practice, basically. But if you're thinking about the candid monitoring, there's no setup required. It's easy training and a learning curve. There's no additional staff needed. There's no cost. It's US licensed specialists that are monitoring. So the software is sophisticated enough to know that your aligner is fitting well or not. And you have a licensed specialist behind the scenes who's checking that for you. So when the patient does get a no-go and they wear it again for one more week and then scan again, someone other than a technician, a licensed specialist, is paying attention to that to make sure that that goes well. If it happens more than once, then you, the treating doctor, actually gets an email that says, hey, your patient was told not to move on because they were a little misfitting, and it happened 2 times, so you should maybe check on your patient. So you do get an alert if that happens, and that is that support is available 365. So it's every day, all year long. You have the candid monitoring behind you, backing you up to make sure your cases are tracking beautifully, keeping your patient on track so they could come in with a finished product. It can eliminate, that monitoring app, by the way, can eliminate a lot of non-clinical support. So when you have patients always calling the practice saying, oh, I lost an aligner, or, you know, I'm not sure what to do with this, and they have questions that aren't really clinical, well, the remote chat here, the monitoring team can handle all of that. So let's say a patient loses an aligner. They can click into the app and order a replacement on their own. So the remote monitoring can handle the replacement aligners. When a patient has a question, oh, I lost my aligner on day 13. What should I do? The team will handle that. You know, they'll tell them put on the previous one. Or I lost my aligner. I need a replacement. They'll order a new one. Basically, you have anything from a chat or an email or a phone call available as support to handle all of the non-clinical questions. Now, if you're not sure how many non-clinical questions come in, ask your reception, ask your front desk team, how many aligner questions do we get that aren't clinical, that don't get to the doctor? Because there's probably, if you're doing any level of clear aligner treatment in the practice, there's probably a number of calls coming in either daily or weekly that aren't clinical, and your team handles them. Well, if your team didn't have to spend that time on the phone, they could be doing other stuff for the practice. So that monitoring app can take away and eliminate all that extra phone calls to the practice right there. Saves you a whole lot of time and energy. Your front desk will appreciate that. When you're thinking about the patient journey, of course, you got to have an appointment and have a consultation, because we're going to need to take some records and get the patient, you know, committed to treatment. So we do need a physical visit, of course, to get, you know, right here. Then, of course, you go back and forth and you do your treatment planning with the technician. So you're going to have, you know, your records go in, a treatment plan will be made. And of course, as the treating doctor, you're going to have the ability to revise it or modify it and or approve it at some point when it's ready and you see that it's everything you wanted it to be. Then, of course, your appointment for aligner insertion goes and takes place. And then the appointments, the aligner checks can be every 3 to 6 weeks. Okay. And this is the appointment, the mid-course correction. If you have to take something in the middle, you take a new scan if things go off course. So when you're thinking about the patient who is going to be seen all the way through the practice, you have to have them come in at every step of the way here. And so coming in for records, consultation, getting your treatment plan put together, delivering the aligners, then monitoring them every 3 to 6 aligners. If it goes a little bit off course and you recognize they come in, they're not fitting properly, you're taking a mid-course correction refinement scan. So there's a pathway for an in-office patient to be treated. Now, if we're thinking about remote monitoring, it's a little bit different. We do need, obviously, to see the patient at the beginning, because we need records and we need to have, you know, some sort of consult where we have, you know, approval or their consent to treat them. But when we do send the records in, an orthodontist, a specialist, is behind the scenes working with the technicians. And so a technician isn't just putting together the plan. You have a specialist behind the scenes that is reviewing that plan to make sure that it's closer to what you're looking for. So now you have an opportunity to have a specialist in the background, making sure that your treatment plan is set up the way you want it, and you have it coming back to you a little more refined and better. You don't have to go back and forth with the technician, so to speak. Then there's a big difference. Once you approve the case, you have a chance here to make something different happen. You can select to have the aligners go directly to the patient or come to the office for delivery. So when I began this process, you know, in my office, what we did was have the first few come in just to see it. I wanted to see it arrive. I wanted to see what the experience was and how that box would present. And then, of course, we had the patient come in and we had them put their first aligner in and take their first scan. And that was excellent for a couple of patients. But once we saw how smooth and easy that was, since then, now for the past year, we've been electing to have all of the aligner kits go directly to the patient. So the entire aligner kit goes to the patient. When they open the box, There's a little card and an instruction, and they've already received an email and text application information, so they download the app. Patient downloads the app, and it walks them through their first scan. Place your first aligner on your teeth, get the little scan box, let's take your first scan, and they're off to the races. They're going to take that scan every 2 weeks. So every 2 weeks, they take their scan, and they would be notified right there in the app, move on to your next aligner. And then, of course, they go right through the case, and then they show up at the end of treatment on track, because the software and the scan will monitor the treatment and keep them on track throughout treatment. There's support in the app 365. So should they have any question that is non-clinical, it goes right through the app, and we take care of it behind the scenes, as opposed to them calling your team at the front desk. So there's a little bit of a difference there. It's a nice advantage. When you're thinking about your options for monitoring, well, you can have a chairside visit, right? The patient comes in to monitor. So you see them every month or 2 months or whatever the interval is. You can take static photos. You can take photos along the way, and static photos over time are a way of monitoring, but you need the patient to come in for that. Or you can basically you can visualize your progress with time lapse. It's a video morph anytime on demand. So you can watch the movement occurring in the mouth throughout treatment and compare it to your treatment plan. And you have access to all of this remotely, because every time the patient takes a scan, it's recorded in their doctor site. So when you log into your doctor site and you go to your patient's file, part of it is the treatment plan, the other part is the progress. So you can keep track of it all you want. You have total control over monitoring this at any time. You get to view their progress. You have eyes on the case at all times. Meanwhile, you just don't have to have the number of office visits to watch it happen. As far as cases go, we'll show you some of the cases that were treated with basically full remote monitoring, meaning patients were only seen for a visit at the beginning and the ending. So seeing the patient 2 times gets you this amount of success. And the most common types of cases that we look at are going to be in the crowded space. So you're thinking about malocclusion. Crowding exists a whole lot more than spacing. So since crowding exists a whole lot more than spacing, we see lots of crowding. Well, we can handle crowding. We can handle a little bit of spacing too. When you're thinking about the deep bite, that's also pretty common. So the crowded deep bite, turns out it's the most common of the malocclusion categories. So crowded deep bites lend themselves very nicely to unraveling with clear aligners. Clear aligners work beautifully in the crowded deep bite space. They also do spacing pretty well, handle spacing very well. But when you're thinking about cross bites, then it becomes, okay, where is the cross bite and how involved is it? Clear aligners are very capable if you're talking about incisors where there's a crossbite present, or a canine crossbite, or a premolar crossbite. The molar crossbites get a little sketchy. The molar crossbites are not exactly clear aligner alone, so they're less predictable. Can you start a case with clear aligners with a molar crossbite? Sure. Would you add auxiliaries? It's possible, because you have 2 choices. You're either going to correct the crossbite or not. If the aligners alone are tracking beautifully and correcting the crossbite, you win. It's not as predictable, but it can happen. If it doesn't, you're prepared. You can add auxiliaries. Clear aligners can be used with auxiliaries like elastics, much the same way brackets and wires are used with elastics as auxiliaries. Braces don't solve everything. Sometimes elastics are used with braces. When you're thinking about underbites, typically the underbite, we're talking about a class 3 bite. That's a little more challenging. Usually that's not a clear aligner alone case. That's clear aligner plus. Clear aligner plus elastics, clear aligner plus headgear, clear aligners plus surgery. The underbite can be challenging, and that's a different category altogether. Open bites, those are possible to correct with clear aligners alone. Our technique of trimming the aligner up onto the gum tissue to have more control over the teeth can help with open bites and closing them. They're not as predictable. So when we're thinking about this space, here we're thinking about, well, the crowded deep bites are pretty solid. So the left side of the screen is where we live mostly. We can start to handle some spacing. And then in the crossbite, it depends upon the teeth in crossbite, and the underbite and open bite are the less predictable ones when we're talking about clear aligners alone. So if we look at patients like this, these are some of the patients we might see on a regular basis. Every now and then, picture number 1, we see a patient where, okay, we've got 2 teeth out of place badly, and we can work on that with clear aligners. Number 2, we've got some spacing, but if it's spacing in both arches, that's pretty routine. 3 and 4 are probably your kind of standard, run-of-the-mill, average, crowded case that walks in, crowded, a little bit of deep bite. And those are, probably the bread and butter in the clear aligner space. And those lend themselves very nicely to be treated, without any attachments in the clear aligner technique. So we'll think about patient number 1 first. So that's a terrific tooth number 10 and 11 over there. And so that's a wonderful opportunity for clear aligners. You can see they're almost transposed, but they're kind of back to back. And sure enough, the patient has that crowded / deep bite with the crossbite as well. So tooth number 11 is in crossbite with number 22, and a fairly dug in crossbite too. When this patient bites down, you can see from the occlusal view how much of tooth number 11 is fully exposed and erupted, but tooth number 22 approaches all the way near the gum line there to kind of block the view of number 11. So you have, a reasonable amount of crowding and an interesting display of teeth here. And we're going to get involved with moving them with our clear aligners. Now, what I mentioned at the beginning of these cases was that these cases are all done with 2 visits, meaning an initial visit to collect records. The aligners are sent directly to the patient, and then they went through and did their tracking and their scans accordingly. And then we followed them, and then they finished and came in and did this without refinement and without additional aligners. So we're basically looking at a 2-visit opportunity. It's basically the least amount of visits you could see a patient in and have it track beautifully thanks to the monitoring. It doesn't mean you have to do every case in 2 visits. It's nice to see the patient in the middle a little bit and kind of keep your, relationship type dentistry alive. Here you're looking at the anterior view, and the anterior view looks like it plays very nicely. We get the crossbite corrected, we get the teeth aligned, we have a beautiful bite for it. And in our next view, we'll get to see the occlusal views of how these teeth are going to progress. So basically, we're looking at all the teeth kind of take their position and line up nicely. And of course, the patient's chief complaint would be in the smile and how the teeth at the front look when she's smiling. The one tooth is shifting out a little bit, the other one's hidden back there. And sure enough, we would love to help with that. As the patient progresses, this is how it would look if you logged into the site. During treatment, you could log into the site and watch how this would play. And what you're looking at is the patient going from 1 aligner to 16. But in going 1 to 16, you can see how number 3 was worn a little extra. Every one of those represents an extra 4 days of wear time. So basically, you're watching number 3 be worn a little longer. Then you're watching number 4 be worn for a significant amount of time. It turns out that the tracking on tooth number 10 and 11 needed the most attention at aligner number 4. So aligner number 4 was used for an extended amount of time until it passed. Aligner 5 was only used 1 extra week. And the patient then rode the entire system all the way to number 16 to finish with perfect tracking without getting additional aligners. So the scanning basically helped this patient get all the way through so that we could get results that look like this. And again, in just 2 visits to the practice. So a first visit and a last visit, and tooth numbers 10 and 11, of course, are well aligned in the occlusal view. The anterior view shows a reduction in the deep bite. It shows alignment of numbers 10 and 11. And of course, the lower incisors are now well aligned. So you have a patient who was able to go through 16 aligners over a course of time, where 3 of them were worn for extra time until the tracking was satisfied the software. And of course, they get to number 16 and get retainers at that point. So you have an opportunity to take something as displaced as number 10 and 11 are and get them to track beautifully just by monitoring remotely. When we get to patient number 2, we had some spacing here. So with a little bit of spacing in the upper and a little bit of spacing in the lower, maybe an edge-to-edge bite. Of course, the patient's chief complaint is going to be the gaps. He would like the gaps closed. And patients like this who are watching those gaps over time might even say to us, the gap seems to be getting bigger over time. So slow change, but it looks bigger than it used to. So of course, this is a malocclusion. We'd love to have a better overbite over jet here, a little more protection in the bite. And having upper and lower space together is very convenient towards closing the space. It gets a little more challenging when we have upper spacing and lower crowding. Those are opposites. So those cases are a little more challenging. This is a very straightforward very straightforward spacing case so that we can work through this. The patient has terrific gum and bone. So there's a Panorex here showing he's got all of these teeth here. Excellent bone, excellent bone levels, excellent roots. So we should be able to do a wonderful job helping this patient. The anterior view is going to show, he already comes in with a nice broad wide arch. All we have to do is a little bit of space closure at the anterior. So it becomes a minimal tooth movement type of treatment, but it can make a big difference in the protection and the occlusion and take away that edge to edge type of bite. So this is the occlusal view showing space closure, which is very nice. It'll satisfy the patient's chief complaint. Then of course we get to the end of the occlusal views here. The occlusal views will show the anterior consolidation and the space reduction. It's not a very significant type of movement. It's very minor, but this again is what you can do with a 2-visit approach, meaning this is one of those patients that was seen at the beginning. The aligners were shipped directly to the patient. They put the first one on, they went all the way through their aligners and then came in at the ending. Hey, you're all done. Perfect. Retainer time. This is the process. So while this is a very simple and capable, space closure case for clear aligners, you recognize that this patient just went straight through from number 1 all the way through number 16 without even having one stage where they had to wear it longer. So every single aligner was 2 weeks each. 16 aligners later, the patient has a terrific result where there are no spaces left. So all of a sudden we're here. The before with the spacing, the after without spacing, and a little better overbite over jet. So you have a little more protection in the tissue there, should start to heal. So you could start to recognize, if you pay a little attention to the gum line, you start getting a little healing in the tissue when you get a little more protection in the bite. So obviously these teeth came together nice. They're parallel. They look beautifully straight. The space is closed. 16 aligners with 2 visits is very impressive. And the candid monitoring allows you to keep track of it should you desire. You can take a look in the computer and see how it's going, or you can just kind of let it fly and see the patient in 2 visits, one at the beginning and one at the ending. That patient number 3, this is a very kind of standard type of mild crowding, moderate deep bite that the patient shows up with and says, I had braces as a teenager. I didn't wear my retainer very well. And here I am, 26. It's been 12 years since my braces came off. And when I stopped wearing my retainer, they started to shift a little bit, but it's getting worse. And, the years are going by and I see the crowding is more and now it bothers me. So this is kind of that patient. On occasion, this patient walks in and says, I never had braces, but it's more common that they did and didn't wear their retainer. So we have an amount of relapse. So this lends itself very well to a wonderful clear aligner case. And again, you have excellent roots, great bone. You have a perfect patient to use clear aligners on. This is another one of those cases that was treated in 2 visits. So you had a beginning visit where all the records were taken, but then everything gets developed and ordered and sent to the patient. They receive it. They put their first aligner on. We'll see the remote monitoring in a moment to see how they tracked all the way through. They get to the ending on their last aligner. They come back to see you and you confirm that it's finished and you give them retainers. Or actually, I should say the last aligner is the retainer in the box. So they come in wearing their retainer. And if you agree that it's perfect, they're all done. They have their retainers already built into the case. So here you're looking at, a commitment to moving all of the teeth to get rid of that crowding. So the back teeth are kind of narrow and leaning in a little bit. So you expand the posterior teeth by uprighting. The expansion of the posterior teeth, all that wonderful uprighting gives you room to align the front teeth with a little proclining. And with expand and procline, you can have wonderfully aligned teeth. Here the occlusal views show moving all of the teeth. So we're moving all the teeth and we create a nicer arch form at a more appropriate arch width. And all of a sudden, what was once crowded is no longer crowded. We just needed to kind of move all the teeth out and away from the tongue a little bit so that we could have full alignment. This pathway can be seen right here on the chart, and then we recognize how it went for this patient. So as they're tracking through, you could see at aligner 7, they received a no-go to wear it and scan a week later. So aligner number 7 was worn for 3 weeks. Similarly at number 9 was worn for 2 weeks, and then they were told by their scan, oh, not yet, let's go 1 more week with number 9 and scan again. Same thing at 10. So with the 7, 9, and 10, you add 3 weeks to the treatment to allow the teeth to stay and track and express what was supposed to happen in the aligner. Then you can get to 16, the patient can show up and you could be finished. So all of a sudden, 16 aligners later, you are finished. And mostly because you had the tracking ability to tell them at 7, 9, and 10, where it was appropriate, wear those a little longer until the teeth fully express that movement. Then you move on. You don't have to have a tracking issue, remain all the way through the aligners, and then end up with 5 or 10 refinement aligners to finish this case. By the time we get to the end, we have just a little wider arch and well-aligned upper teeth. The lower, a little wider, upright posterior teeth. You can tell there's a difference in the tongue space. So if those of you out there who are paying attention in the airway space or thinking about, the tongue at all, you recognize on the right side of the screen, the tongue has more room. Anytime the tongue has more room, you just made an improvement for the patient. But anyway, the posterior teeth are now upright. You have vertical loading of your back teeth. You have a reduced deep bite. You have remodeling of the gingival tissue to be perfectly even across the lower incisors. You have well-aligned teeth, and you got more room for your tongue. So you satisfied a whole bunch of things here, not the least of which was for the patient, I've got crowded teeth. And then, of course, they throw a little whitening gel around, and you can reduce the staining level. So you have a happy patient with their chief complaint satisfied. And again, this is an example of kind of traditional crowded deep bite that we'd see on a daily basis in a dental practice, doing this with without office visits, meaning a beginning and an ending. Now, it doesn't mean you have to follow that rule. If you want to see the patient in the middle, or 2 visits or 3, whatever the number of follow-ups that you feel is appropriate for your practice and maintaining a level of connection and relationship to a patient is appropriate. We're not trying to tell you that you should see your patient twice, but now you have an opportunity where you can do this with incredible remote monitoring. And with that monitoring, you have access. Your eyes can be on any one of these 2-week monitor scans if you chose to. So basically, you have the most amount of oversight because you do get to see every single aligner if you wanted to, but with the least number of office visits. Very similar to patients we'd see on a daily basis in a dental practice. You've got your mild, crowded, moderately deep bite here. And of course, you would hear similar story. This patient is, the top teeth are close enough and the smile isn't so bad that this is a patient who could say, yeah, I never had braces. They weren't so bad, never got around to doing anything about it. Or you might have the patient who says, yeah, had the braces, got a retainer, didn't wear it, and then my teeth started shifting, but now they're bothering me and I can see it more in the photographs at family functions. You get stories like this. Meanwhile, while this is a very common type of look and or patient that we would see in the dental practice on a regular basis, this lends itself to a really nice clear aligner case that you could treat with 2 visits. So again, we get to see what would happen in 2 visits. You have great roots, you got great bone. Here you have a wonderful candidate to do clear aligner therapy on. And of course, this anterior view will show you all of the teeth adjusting slightly to give you full alignment of the teeth. One of the things that the 3 out of 4 cases had some crowding. The one was a spacing case. One of the things that we have in common with all of these, there was no IPR performed. So these just happened to be cases where there was no IPR performed. And what you're recognizing is that these types of cases, without any attachments and without IPR, you're not only reducing your chair time in less type of techniques you have to perform on the patient, you're also in a position to reduce your chair time by the monitoring. So we get to watch the occlusal view play nicely, and then we'll switch over to the occlusal views here. So we saw the anterior bite happen nicely. So what you recognize here, all the teeth move. They're all moving slightly. So as the posterior teeth expand a bit, then the front teeth can align. All of a sudden you get rid of your crowding. You've got a wonderful position for all these teeth. None of these teeth are moving terribly far. If everybody moves a little bit, you can accommodate a mild amount of crowding rather easily. And then, of course, we get to the point where we take a look at their scans along the way. And what you can see here, the patient goes from 1 all the way to 16. 17 is the ending, their retainer. So you get to number 9, and you recognize there's no number 10. So one of 2 things happened. Either the patient just didn't scan number 10, which is likely, or they missed it and didn't wear number 10. It's more likely they wore it but didn't scan it because the time frame, there's a gap between 9 and 11. So very likely what happened is the patient wore number 10, forgot to make their scan, and then obviously they moved on with a 2-week interval. And when they scanned 11, it was still tracking beautifully. So here you have a patient who wore 16 aligners. And again, in 2 visits, there's a beginning visit where they came in for records, agreed to treatment, and next thing you know, the aligners are sent directly to them. And then they can wear all of their aligners and come back at the end to have a result like this. So we get a slight expansion of the arch, well-aligned teeth. All of a sudden you have a less deep bite. You can see the gingival remodeling happening already. So the tissue is starting to even out across the lower incisors. You have a little more room for the tongue because the posterior teeth are upright now and the crowding's all gone. So this is, again, the opportunity where you could reduce your chair time and see the patient in 2 visits at a minimum if you wanted to do that. Or again, having that option doesn't mean you have to do that. You can always see the patient at a reduced interval. Then maybe you want to see them in the middle of treatment somewhere just to check them. We were doing that for a while. Now we're kind of comfortable in just talking to the patient about how their schedule is versus the tracking and doing the monitoring with the candid monitoring. Do you want to have an extended time between visits, or you want to come see us every few weeks? We can do whatever they like. And since number 2 was convenience on the list for the patients, we're trying to accommodate them on every turn. So it helps us quite a bit. As far as telehealth, this is basically telehealth when you're doing this type of monitoring with your candid monitoring. And the efficiency was shown here, where what they did was they looked at a control group, conventional treatment, aligner patients. They had 100 of those. Then an experimental group, the remote monitored aligner patients, they had 100 of those. And the office appointments were reduced from 7.2 to 2.1, thanks to the remote monitoring. So that's 71% fewer appointments. As far as staff utilization, when you're doing clear aligners, a lot of our team members do some of the stuff. So instead of 10.5, you're down to 4.4. So staff utilization becomes much less. That's 58% less. The refinements is the biggest category right there, because in the control group of 100 patients, you had 91% refinement rate, whereas with the remote monitoring 100 patients, you had 14%. So that's a big decrease in the number of refinements there. So an 85% reduction in refinements thanks to the remote monitoring. As far as the duration of treatment goes, you had a 17.3 and a 10.6. So you had a reduction in treatment time. Now, refinement and duration of treatment time should go hand in hand. If you're doing refinements, you're having extended treatment time. If you're not doing refinement, the case is done in less time. So all of a sudden you recognize that, well, less refinements means less time, means more profit. It's more profitable. Can you attract more patients to your practice? Well, we were talking about the two things that patients were looking for when they were seeking out clear aligner treatment, and it was convenience and cost. So convenience, well, patients want a better experience, not more time in your chair. None of my patients are looking to spend more time with me. In fact, more often they say, oh, you're very nice, and I'm sure you're a nice person, but this is the last place I want to be. I'd prefer to be anywhere else. They have a list of places they'd love to be before your chair. So cost, lower overhead, reduced chair time. You have an opportunity there. Doesn't mean you have to charge less. The idea is when you have a clear aligner system that can reduce the number of visits by that amount, combine it with a lower lab cost and combine it with a lower general overhead, you have an opportunity to have a dynamic of, well, we might be able to reduce our cost, which makes it more attractive to more patients. And so if you could reduce your cost for your clear aligner treatment a little bit, you might engage more patients in clear aligner therapy. That's always more profitable. Meanwhile, you're not losing on the case because you still have an amount of profitability thanks to the lack of the chair time. So that's an introduction to a clear aligner technique that uses remote or candid monitoring. And because of that, we get to kind of have a slightly different approach to our clear aligner technique. We're going to open it up to some Q&A now. Okay, so let's get some questions here. So the first question comes in, comparing attachments to no attachment aligners, are there limitations? And so there are. And so the number one limitation in the attachment category is going to come from the open bite. The anterior open bite is a little more predictable with anterior attachments, as opposed to just using clear aligners alone that are trying to engage all the gingival undercuts. If the attachments alone don't satisfy, then you're defaulting to buttons and elastics, which can be used in any of the techniques. So if I was thinking about the difference between no attachments and attachments, the number one category would be the anterior open bite. Any other category, then you would have the same amount of control thanks to the aligner engaging the undercut versus the undercut being blocked out, and the aligner having more rigidity and less flexibility thanks to the 2 millimeters of gingival overlap. So basically, we would be thinking about anterior open bite as the main limitation. Any other category of malocclusion, the same amount of limitation would apply, that if you can't get it done with attachments on the teeth and you can't get it done with clear aligners alone, you would default to elastics. The next question is, can we treat a patient with lower incisors tipped lingually with aligners? Well, yes, that's a nice question. Lower incisors that are crowded are usually kind of leaning a bit lingual, and they need a little bit of procline or tipping forward. So when you're thinking about treating patients with clear aligners, the crowded cases have posterior teeth leaning lingual or have excess lingual inclination, and the anterior teeth are crowded or overlapped and have a little bit of lingual inclination. And what you're doing is you're uprighting those teeth. So the posterior teeth get uprighting. So expansion is a word because it says what direction we're going. We're moving the teeth out or wider, but the technique is actually uprighting the posterior teeth. Then when we're thinking about the front teeth, well, expansion or proclination is for the forward. So moving forward, we call it procline. And then next we start thinking about what's our best opportunity to procline front teeth? And it's actually clear aligners. Clear aligners are better suited for proclining incisors as opposed to braces. Brackets and wires don't procline teeth very well, whereas clear aligners do, because they're basically expanding all the posterior teeth to allow for the proclining of the anterior teeth for full rounding out of that arch, into a beautiful arch form. So we think about any teeth that are lingually tipped, clear aligners are a better pathway to uprighting them. Is IPR usually needed? So the answer is no. In fact, IPR isn't a need, it's a choice. You don't need IPR, but you can use it. So IPR is a technique, but not a need. The short story is that no patient needs IPR. It's just a tool that you can use to help teeth get straighter. What they really need is just more tooth movement. What IPR does is it substitutes for tooth movement. Taking away in between teeth can reduce the amount of tooth movement you need that you would have to have aligned those teeth. So the more you're willing to commit to moving all of the teeth, the less IPR you get to use. So probably 15 or 16 years ago, when I started teaching about clear aligners, I was teaching techniques to reduce and or eliminate your IPR exposure. And so I've been teaching in the expansive aligner category for the last, I think, 16 years. And the idea was that no matter how ridiculous the crowding could be, I've already treated those cases without IPR. The more crowded the case, the more collapsed the arch. You just need more tooth movement. So you upright the posterior teeth a little more and you procline the anterior teeth until you have full tooth positioning and alignment. In the end, you're not moving the teeth past where they belong. You're just moving the teeth where they do belong. So when you're moving teeth where they belong, good things happen. And when you're doing it with removable clear aligners, you have a wonderful cycle of pressure and tension. It's very protective of the gum and the bone. So basically, when you're thinking about, is IPR usually needed? The answer is no. Can you use IPR in certain circumstances where it might be helpful? So we could think about black triangle reduction. Patients who come in who have a history of maybe some gum and bone loss, and there's a little black triangle in between teeth. We call it like a poppy seed look type of thing, or a little piece of salad looks like it's stuck. You can use IPR to reduce or sometimes eliminate a black triangle. So it could be used as a cosmetic technique to make a more appealing smile line without the black triangle. You could use it in a restorative case where maybe you have a patient that has a lot of old crown and bridge restorative dentistry, and maybe some of the old dentistry is oversized or over contoured. IPR could be used in a position where it could benefit to bring you back to a more appropriately tooth size condition versus or a more natural tooth size condition. Whereas, did you have those crowns sized perfectly when they were originally made, or were they making up for the tooth being out of position? So IPR isn't so much a need as it is a tool. You can use it. Doesn't mean IPR is bad. I'm not saying IPR is bad. I just do very little of it. And the cases you saw today were done without any IPR. All of the cases that I treat with Candid are done without IPR. So I basically practice without much IPR today, very little. With cycling pressure with the aligners, do you see less root resorption, even though the timeline of wear is less? Yeah, the answer is you really don't. You're not going to see root resorption from clear aligners unless you're doing something that is really outside of the scope of normal wear time. So because you have the ability to take the aligner on and off, you're not likely to find root resorption unless you wear the aligner 24/7. If you wear your aligner 24/7 and you change them a little bit sooner, you might see some root resorption, but it's not likely to happen with clear aligners. Root resorption is something that occurs when you are dealing with fixed appliances, so fixed braces. Fixed braces have an opportunity to deliver root resorption, and it's a little easier to do that with fixed braces because there's a lot of pressure on the teeth. And then, of course, based on the wire sequence and the types of wires, most of the root resorptions that we're accustomed to seeing on our patients were done in the previous generation of patients where the wires were stainless steel. Stainless steel was a big culprit when you're thinking about root resorption issues. So now that the wires have faded more towards the nickel titanium, NiTi, and or biothermal kinetic type wires, they're kinder, they're gentler, and they don't cause as much root resorption. It then falls back to maybe a poor technique. You put in the wires or change them too soon, so the stress was too tight, or you wore the braces just too long with fixed pressure on the teeth. Clear aligners don't usually cause root resorption. It's hard to find that. And certainly it wouldn't necessarily cause any type of recession or bone loss either, because you don't have fixed pressure directly directed on one side of the tooth only. Next question, do you recommend clear aligners for kids, or is traditional braces preferable for this age group? I use clear aligners in mixed dentition and above. Again, because of the compliance issue, you just have to have the right kid. Clear aligners are very capable in any age group. because they move teeth and they do it in a removable fashion, but you just have to have a child who can wear it well. So if you have the right child that can wear aligners well, then you could begin to test that out. I'm not the biggest fan of traditional braces as they just align the teeth and they don't really develop the foundation. I'm a bigger fan of for kids developing the foundation first. So you want to have your maxilla and your mandible get its full growth and development, then you work on straightening the teeth second. So as far as kids go, clear aligners do work in mixed dentition and even teenagers. You just need to have the right child to do the compliance. Maybe in the scanning category, since we're doing dental monitoring, with the Candid monitoring app, maybe that produces more compliance because the child now would have to scan, or parent would have to help them scan at a 2-week interval, might keep them more honest. Now on a lab, next question, on a lab RX, do you need to state that you want no attachments, or is that the default? Most interestingly, the Candid Pro solution doesn't have any attachments. There are no attachments at all. So it is not part of the RX. You don't have to ask. There are no attachments involved with Candid Pro technique. Do you have any issues with open bite? Zero. So this question could mean two things. Number one, do you have any issues with open bite? Meaning, do I have any issues treating open bites that walk in that way? If a patient walks in with an open bite, I'm very capable of treating it. I can treat it in any number of ways. Typically, I choose clear aligners to treat open bites, and sometimes they do result in clear aligners plus auxiliaries, maybe some buttons and elastics. The other way you could interpret that question, do you have any issues with open bite? Meaning you're treating with clear aligners, but you're getting open bites as an end result or as a side effect or as an adverse outcome. And the answer to that is, well, that is purely a technique issue. If you're using clear aligners and you're getting an open bite, it's all in the technique, and that poor technique that was put into the treatment plan has delivered the open bite. And so the answer to that question would be no. In 18 years of doing clear aligners, I have never had a posterior open bite because I do not do retractive orthodontic techniques with clear aligners. Clear aligners are meant to move the teeth away from the tongue. And if you avoid retractive techniques, you do not have to experience the posterior open bite nightmare. So I don't have any of those. I don't do retractive orthodontics. Let's see here. Does the patient need to be in the same state as the dentist? Well, the Candid Pro is an in-office technique. So Candid Pro is in your office. So you are in your office, your patient comes in, and if you would like to treat them with Candid Pro aligners, you would take your records and send them in. So the patient you're treating is in the same office as you. So the answer is yes. I think what this is referring to is the direct to consumer. And the idea there is that Candid itself has its origins in direct to consumer, but that's about 4 or 5 years ago. As of January, Candid decided to switch to an in-office dental-driven technique. So it is no longer direct to consumer. Candid shut down all 42 of their locations. They are no longer a direct to consumer. They have moved into the basically dentist-driven and patient care in-office treatment. As a Candid Pro aligner system that is being used, the patient comes to your office, you do your records, your consultation, you can deliver the aligners in your practice, or you could have them sent directly to the patient, and you could choose to see the patient on any interval that you choose, including a beginning and an ending session. So that allows you the most amount of free chair time for your office. Now, what is the lab cost for a typical case? That is a good question. And, to be honest, I don't know what the lab cost is. I'm going to guess it's somewhere around $1,200 to $1,400 for a full case. But we could certainly have that question directed to the Candid Pro hierarchy, and we could get you a more accurate answer. I know it's a very competitively priced system at this point in time. Now, is this system good for Class 2 cases? Well, you can use clear aligners to treat Class 2 malocclusions. And the idea is, are we doing it with elastics? Are we doing it with myofunctional therapy? Are we doing it with any number of auxiliaries that can be used similarly like braces? Braces alone don't correct a Class 2 to a Class 1. Elastics and or other auxiliaries can be used to help correct the Class 2 to Class 1. So brackets and wires are a piece of orthodontics, and then with auxiliaries can work on Class 2s. Same thing with clear aligners. Clear aligners are terrific when used with auxiliaries. You can treat a Class 2 or even a Class 3 with it, depending upon the degree of the Class 3. What is the maximum rotation that can be achieved with clear aligners? Is it feasible to rotate a tooth 90 degrees? 90 degrees isn't so bad. Well, 180 is tough. So I don't recommend trying to do 180 rotation. That example would be like a premolar that has the buccal and lingual cusps reversed. I would not attempt to swing that tooth all the way around the 180. But when you're thinking about 90 degrees is not so threatening. Incisors that are 90 degrees, well, they're like a flat screwdriver shape. So those are the easiest to rotate. The canine puts up a little bit of a fight, but when you have the monitoring, you would have a scan telling you that there was tracking to move on. Otherwise, you would go ahead and wear the aligner a little bit longer. So 90-degree rotations come in rarely. And when they do, it can be a little more challenging. So we might use the word less predictable. And if you had candid monitoring, you'd be able to follow it along the way to make sure it tracked. If you didn't, you go basically clear aligner plus. And clear aligner plus means maybe a tooth like that would get a button and an elastic, because you can combine an auxiliary like one little button with an elastic, and all of a sudden you can help a tooth like that rotate throughout treatment. So the 90-degree tooth comes in occasionally. I always attempt to do that with aligners alone. Most of the time, aligners alone are going to solve the problem. But if I have to, I can add the button and elastic, which you could use with any system. You might have missed this, but what about retention? Do you do lingual wires? So retention, the way Candid Pro is delivered, the retainer is in the box at the very end. So thanks to the Candid monitoring, you're very likely to be on track. So they provide that first retainer. It is in the box. The patient would come back to you wearing the last so-called aligner, but technically that's their retainer. And if they look amazing and everybody's happy, you're done. They have their first retainer. When it comes to adults, I do not add lingual wires. So adults that are treated with clear aligners get clear aligners as retainers, and they wear them to bed every night. And then for as long as they last, you just keep repeating the delivery of those retainers at a fee that you see appropriate over time. When it comes to treating children, which I do a lot of, then children, yes, I do put the lingual bar on the kids. You know, when they're 13, 14, 15, whatever age they're coming out of their orthodontics, whether it was clear aligners, expanders, brackets, wires, guidance appliance, makes no difference what we were doing. If they come out of that and they're a teenager, I like the lingual bar. It's a protective, it's a nice safety net. I give them a lingual bar, but then I make a clear retainer over it. So they do end up getting an upper and a lower clear retainer as well. That concludes the Q&A. That was all of the questions that were entered. There's a little scan code there. If you choose to learn a little bit more about this, you'll come across me again. Otherwise, thank you very much for your time and attention this evening.